Aloha and good evening. I am Mark Alexander, Executive Director of the Hawaii Medical Association. Thank you very much for joining us today for our conversation at HMA, a program which features discussions with physicians and other thought leaders in the healthcare arena. For this edition, our special guest is HMA member Dr. Stefanie Park, Vice President and Chief Medical Officer for HMSA. She will be speaking on prior authorization as our guest speaker for our new member gathering here at HMA. Format for today is a little bit different than in previous conversations. We'll have a presentation by Dr. Park for about 30 minutes. HMA members have had the opportunity of submitting questions to her ahead of time, and she's integrated those questions into her presentation. After her presentation, we'll close the formal part of this program, and then we'll continue here on site with further conversation as we enjoy the special meal that has been prepared in honor of Mardi Gras and our guest, Dr. Park. We always want to hear from you all, so please feel free to email us at info@hawaiimedicalassociation.org or contact us via our website, hawaiimedicalassociation.org. Now it's my pleasure to call up our HMA President, Dr. Elizabeth Ignacio, to introduce our special speaker. Dr. Ignacio.
Well, aloha and good evening, everyone. Welcome to our new HMA members here in the room and also online. I'm excited that we can have this great event scheduled where we get to have conversation with HMSA with Dr. Stefanie Park. So I wanted to start by letting you know a little bit about her. So Dr. Stefanie Park, she is the Vice President, the Chief Medical Officer at Hawaii Medical Services Association, HMSA. And as a Chief Medical Officer, Dr. Park provides clinical guidance for HMSA's business decisions, and she supports the company's journey as a healthcare organization. In addition to her leadership, she manages external relationships, healthcare providers, partners. She oversees the utilization management initiative, and she leads the work stream dedicated to improving the HMSA employee wellness. Dr. Park is an internal medicine board certified physician. She, in addition to her key role at HMSA, she served as an associate professor of medicine at the University of Hawaii, Jackson. She worked as a hospitalist with medical specialists of Hawaii before joining HMSA in 2013. She's born and raised and educated in Hawaii. She's a graduate of Punahou School. She earned a bachelor's degree in biology at the University of Hawaii at Manoa and her medical degree at Jackson. So she completed her internal medicine residency at the University of Hawaii Internal Medicine Residency Program. And in 2022, Dr. Park also earned an Executive Master of Business Administration with the Scheidler College of Business. Her greatest joy is spending time with her daughter, Mary. Understand that. And she achieved work-life balance with exercise. She does some painting and she does some healthy doses of self-care. So she's a huge Disney fan, that's neat to see, and firmly believes that each healthy day is a blessing. I'm really pleased to welcome Dr. Park to speak with us.
So thanks so much, HMA, for having me tonight. Thank you, Mark, for setting this up. Thank you so much for that lovely introduction. You know, this topic has brought a lot of attention this legislative session, and I think it's good to have this safe space to have a conversation about, you know, where we're at and what we can do together to make progress together. So a lot of this you've now heard in that lovely introduction. I really pivoted to administrative medicine in 2013 when my daughter was 1 year old. So I've now marked 12 years at HMSA and my daughter is a teenager. So that brings a lot of excitement when it comes to work-life balance. But administrative medicine is where I made a full pivot starting in 2020. I started at HMSA initially as a rank and file medical director for the first 5 years and then made a pivot into management. It quickly became apparent to me that, you know, I needed to is augment my clinical skills with more business making capacity. And so that was the decision to go back and get an MBA. And it turned out that it was a pandemic degree. It was very interesting because it was a distance learning program to begin with. And gosh, it was perfectly suited for the time. So sometimes life just works out. I spent the past couple years mostly overseeing our pharmacy area before I was asked to make a pivot to medical management, the area I'm currently speaking about. Medical management is what is all the prior authorization activities within HMSA. It's otherwise known as utilization management, but the HMSA term for it is medical management. Clinical integration is where we are trying to do better communication with our healthcare provider partners. And, as we aspire towards becoming a healthcare organization at HMSA, hopefully more of these conversations will happen in a timely manner for better collaboration. And the last piece of my time, I'm the executive sponsor of our Malama Ola program, which is the employee wellness program. So this is where HMSA is showing up in with walks and also trying to inspire our employees to be the best version of themselves so they can do the important work that we need them to do. All of this, I get asked, not infrequently, do I ever regret the decision to pivot from clinical to administrative medicine? Well, I need to share that there are so many opportunities to do good work within HMSA that, there's never a dull moment. And I always feel that there's more of a need to, just do as much as possible. So every day I go to work, I think about how I can create a healthcare experience that's truly worthy of my friends, family, and so getting a little more into what we're here today to talk about. I just wanted to set the stage. There's a lot of administrative burden out there. And what I'm focusing on today is kind of the more narrower focus, which is a subset of administrative burden, which is prior authorization. I also just wanted to be clear that I'm talking only about HMSA and its processes. I don't have authority or knowledge about other insurers' processes, but I can commit my effort to working with you for HMSA's processes. So as a general statement, the goal of prior authorization is to prevent fraud-based and best estimates are that there's about a 30% waste. Our current processes are kind of more of a shotgun approach rather than a scalpel, and my hope is to change that as we work together to modernize our processes and move forward. The other thing I want to say about why prior authorization and utilization management is necessary is because all these medical interventions that are available these days are super awesome, but they're also super expensive. I think it was miraculous when the cure for hepatitis C came out. We were kind of like, nervous with the price tag of $150,000. I think it was about 5 years ago. That seemed like it was super expensive. But just this past week, we approved gene therapy that's $3.2 million. And all of these GLP-1s that are so amazing are also super expensive. So trying to figure out how we can use the limited healthcare dollar to really get people what they need to manage their condition. So I would be remiss to talk about prior auth without giving a little bit more background into the finance of healthcare. So at the highest level at HMSA, we have about 65% commercial members. We have 30% Quest and 5% Medicare Advantage members. This means a lot of audits, a lot of rules to be followed, and a lot of special requests by large special employer groups. Also at the highest level, where does our money come from? As a general statement, about 35% come from government programs, about 40% comes from employers, and maybe about 25% comes from premiums. So starting on the right side of this graphic here, for every dollar, HMSA spends 93 cents on healthcare benefits. So that's the care that people receive. They spend about 7 cents in administrative costs on average. If you actually look at our 2024 annual report, the administrative expenses was reported at 4.6%. In contrast, businesses nationally spend 20 to 25% of their revenue on administrative costs. So I'm going to put a pin in that, and we can come back to that in a little. On the left side of this graphic here, I have a graphic from AHIP, America's Health Insurance Plans. And it kind of gives a breakdown of how the healthcare dollar is spent. And so you can see on the far left, prescription drugs are taking up a large portion of the healthcare dollar. You know, at HMSA, it's closer to 30% is what we're spending on medications. And you know, with the rising costs of cell and gene therapy, as well as the GLP usage, you know, it's going to be a bigger percent. I also want to bring your attention to the yellow bar. That's where our physician reimbursement is. You guys are competing with prescription drugs and hospital stays for this singular healthcare dollar. So, you know, there's no magic. There's no magic in healthcare. There's no magic anywhere except Disneyland. There's just this $1 that we're going to have to try and divide up amongst them. So getting into more of the meat of today's talk, I'm going to digress a second before I get into these stats to frame a little bit about, well, to share a story about Our Iceberg is Melting, which is a book about change management by John Cotter. This is it's kind of like our medical management theme right now. You know, CMS has put out interoperability and prior auth requirements. It put these requirements out in January of 2024. So we've had a little bit of time to like digest and understand these things. But for those of you who aren't as familiar, I'm going to summarize. 1126, this prior auth rule says that we must have turnaround time 7 days for our decisions, our standard decisions, and 48 hours for our expedited decisions. And this is the, our iceberg is melting. Currently, we have 14 days. So I'm telling my team, because our iceberg is melting, we need to do things faster. You know, we need to figure out, you know, if we have the same people, processes, and technology, we're going to have to decrease the number of widgets that we put into our machine. So we'll get to more about that later. The second part of the mandate is around metrics for reporting. And the due date for this is 3/31/26. So a little bit after we're supposed to make the decisions faster. And this one is saying that you need a list of all the things that you require prior auth for. You need to report on the percentage of urgent and non-urgent requests that were approved, denied, then approved after appeal. You need to report on the average time between submission and decision. And you also need to report on the percentage of prior auth requests for which the time review was extended. So typically this means, shucks, you're missing some additional information that was necessary, like the clinical note, to make the prior auth decision. So we're gonna extend the time a little bit so we can get the information to make the decision. The last part, this one is due 1/1/27, is on interoperability. And interoperability is basically the ability of computer systems or software to exchange information. And what the interoperability mandate is asking is for healthcare payers to enable programming interfaces to allow the electronic exchange between patients, providers, payer, and prior auth decisions. So you can understand better what we are doing, and also decisions will be able to be made. So when you think about it, it's actually a little backwards, because you're like, wouldn't you want the interoperability before reasonably decisions could be made faster? But alas, we need to do the best we can. So back to my slide. You know, some of these numbers look a little different than what we initially reported out in the statement, and this is kind of there's a lot of work in progress as we're getting to the reporting. So please bear with me as we try to get our data in one place with better reliability, and so we can provide better transparency. So with the initial report, I forgot to add in some of our vendors. So the 157 million cost avoidance that you see there is a combination of what CVS saved us. That's about $77.5 million. Avalon Genetic Testing saved us 1.3 million. Evolent, which is our beloved vendor that does all of the advanced imaging. I'm saying that tongue in cheek because we're going to get to that soon. Saved $12.3 million, and then HMSA prior auth activity saved $66.5 million. So that's how we got to the 156. Total claims paid. That's just a rough number of everything, you know, like PNFs, drugs. The 433,000 PA requests, that's what we made decisions on. And there's a lot of things that people submit prior auth for that actually don't require prior auth. So that's inflated the number a little bit. You know, we're working on better ways to provide better information about what actually requires prior auth. So those submissions can be hopefully reduced and stopped. So when we get to this final denial rate here, I initially was pretty happy with that. You know, I was like, gosh, only 9 to 10% of things are being denied. And as I had thought about it a little more, I was like, oh my gosh, that means 90% of the time you've put in an auth for something and it's kind of like wasting your time. So, you know, there's a balance to this that I think we have not achieved just yet, but this is a place to start, and I think we can move towards something different. So let's take a look at our current state of and it's, you know, there's no question that the current state is not acceptable. You know, 80 to 90% of our prior auths are received by fax, which is crazy, right? It's an antiquity. If you ask a teenager these days what a fax machine is, and you tell them it means like a phone line, and then like prints things on paper, you know, they'll be like, you use that for some of the most important decisions for people's health right now. So, you know, there's we've got a ways to go, you know, and this manual process within our within my department is something that I'm really eager to find modern technology solutions for. And when I say I dream of Domino's, you know, it's not just because I love carbohydrates. It's because I'm obsessed with this Domino's tracker. You know, something so simple that provides so much information about like prior auth status is something that, you know, we're hoping to build to provide more transparency into the process and just clear information about, you know, what is needed for next steps, because often we are stuck on the order, like, shucks, we didn't get the full order, yet you think you submitted your full order. Sometimes you think you submitted your order, we never even received the order yet, you know, like, but something as simple as we received your order is complete, will go a long way, I think, in reducing some of the frustration that we have. So I dream of the Domino's pizza tracker. We don't have it quite yet, and I think that that really adds to a lot of the frustration that people have because there's this, gosh, this is a little bit nerdy. It's so prevalence-induced concept change is something I think about a lot, and this is the big gap between the retail experience and the healthcare experience. You know, like how amazing is it that you go on Amazon and you like press a few buttons and then like something comes to your door a few days later, or Target even you press a few buttons, you get all the things you want in the trunk of your car as you drive up. No, but yet when it comes to healthcare, you know, for someone who's now used to this level of service and convenience, accessing healthcare and it's no, it can be very hard to understand, hard to access. It's emotional, you know, and it's also can be very, very expensive. So all of these things make the healthcare experience compared to the retail experience, which has a lot of price transparency in it as well, just seems so much more frustrating. So how can we get to somewhere better? Well, that's what we have to work together. One more thing I wanted to touch on before I go to my next slide is another thing I dream about. It's better denial letters. And not because we want to give more denials, but because I hear the feedback about how our denial letters don't make sense. And sometimes people will send them to me and they'll be like, Steph, did you really like, did someone who has English as a first language really like write this and send this to me? And there are so many opportunities for improvement. That is one of them. But really making clear when something is a benefit denial versus a medical necessity denial, that's like a fundamental principle that I think is maybe not super clear in our letters. A benefit denial is really the employer group's plan does not cover this. And in some cases, it's something like alopecia. Alopecia is not covered, period. Like it doesn't matter that these treatments are effective, known to improve health outcomes, like regardless of the medical appropriateness of the treatment, it's not a covered benefit. And so the decision making never goes to the science and the medical evidence. It's not a benefit. And it's not often that those are overturned. The other thing that we commonly run into are, there are some what we call grandfathered medical plans, which don't cover Affordable Care Act services. So these are really the basic screening services. And this has caused a lot of kind of angst and frustration when these denials come out. We're not denying it because it's not medically necessary or not appropriate. It's because the employer group who pays for the plan does not have it as a benefit. And so I think clarifying this language and helping providers to really understand what are benefits and what are benefits of the individual medical plans will hopefully, it may not, ease some of the frustration for the denials, because at the end of the day, a denial for something you think is appropriate will still be frustrating. I also wanted to share letter language requirements. So I apologize if sometimes you've gotten the letter that is intended for your patient. I found out that letters are required to be written at a 4th grade level for class integration and at a 6th grade level for our commercial plans. And so making sure that these denial letters have clear language at a physician level is something that we're going to work on. So clearer, more transparent language is something that we will definitely get to. In the meantime, other things that we are aspiring to, and it seems so far away when I look at our fax machine. We just have to start where we are, use what we have, and do what we can until we can get to this one modern platform which will give us these faster decisions with hopefully real-time approvals. And we've had some real successes with some smaller pilots, getting real-time approvals for services using technology. And we're looking at better technology to expand this to hopefully at some point all of the decisions. One thing that I think is clear, reduction in prior authorization scope is something that we need to do. You know, there's for things that are approved, like 97% of the time, like shoot, we should take this off. You know, like that's wasting everybody's time. And so using our data to identify this is something that we're trying to build with our corporate analytics team right now. The transparency tool, Domino's Pizza Tracker, as well as a search tool, you know, like, hey, how come there's no Google for requires prior auth? You know, shouldn't you just be able to type it in and it should tell you like not only like yes requires prior auth, but what the criteria is in a simple checklist. So yes, I believe that that's absolutely necessary and that we should build it. Because you're busy seeing patients. That's the hard thing, right? We should not make getting what you need to care for your patient harder. So the next one is standardized policies. Sorry, that's a typo. Standardized policies across lines of I realize it's confusing. Medicare criteria, commercial line of business criteria, Quest, you know, it's like, they're like, shucks, this is my patient. You know, I'm not treating them differently based on their line of business. So having the policies more standardized is what my team is working on. We've already gone through denials with clear and consistent rationale. Self-service tools, that again is the Domino's Pizza Tracker. You know, like, why would you spend an hour waiting to talk to someone in the Philippines? Then look at it on the computer and get this information yourself, right? Absolutely. And a fast pass system. You know, this is something I'm actually the most excited about. We've delved into it's been called different things, gold party, fast pass, you know, but having I think maybe we need to take a step back and like first agree, like what criteria are we following? Are we following NCCN for cancer care? Shoot, I'm really sad that they sunsetted choosing wisely in 2023. We used to love coding that, but National Society's guidelines are kind of like, can we work with you to agree that we should follow these things? And when these things are consistently followed, you know, fast pass. So let's work together. You know, I think we've historically done these things in a silo, and I think because insanity is doing the same thing and expecting a different outcome, we should try something a little different. You know, like let's talk about these programs as we're rolling them out. You know, the first iteration, for better or for worse, will be based on our claims data, which I'm finding is not quite as facile as some of the data that health systems can provide. We had a small pilot with HPH where they were able to pull total cost of care and quality, like lists of their providers that were excellent in these things. I was like, gosh, how come we can't do that? That would be amazing, you know, because at some point, you know, we're going to have like these are great lists. I believe that they're valid, but at some point our team is going to want to verify as well, and we need to up our game in terms of analytics and I guess data, like just using our data to make better decisions. there's something really interesting that came up in some of the administrative burden work groups that I've been in, and it's the concept of a red card. And this is kind of like the inverse of a fast pass. So like fast pass, you're like, okay, the top providers are the ones that are given a free pass for some of these more administratively burdensome requirements. But shoot, what if we got to a place where we presumed everyone was doing the right thing and just identified our outliers, based on that 80-20 principle, right? That 20% of the people are causing 80% of the fraud, waste, and abuse in medicine. Shouldn't we focus our utilization management activities on that 20% that have the red card? This could be tricky. So we'll need your help and partnership with this, because, gosh, I think it could be very emotional once we come out with these lists. So let's work on this together. The other thing is, gosh, medical knowledge doubles every 72 days. And that's incredible, especially for busy providers that are seeing patients, but already working 14 hours a day. When you get the denial based on something that we think is evidence-based medicine that is not readily apparent because of these rapidly emerging studies, like, hey, could we maybe partner on CME activities based on where we're seeing high denial rates? Maybe that's an opportunity for us to work together in figuring out how we can improve, I guess, consistency between practices and kind of raise the boat for everybody. And these are some things that I wanted to share that from Blue Cross Blue Shield that are suggested. Stop PA for in-network providers for low-cost services, frequently approved services, mental health and substance abuse disorder treatment. Interesting. Yes, I want to, sounds good. That's an interesting place to start. Also, reduce frequency of prior auth for previously approved services needed to monitor and treat chronic or progressive illness. I feel like we've made a few steps in this direction in our pharmacy. It used to be that medications required reauthorization every 3 months. Now it's so we're making steps in this direction, but certainly there are more opportunities for collaboration and working together with you to figure out what matters the most and how can we address maybe some of these fast pass or red card programs of the future. So our work is just beginning. I just pivoted into the medical management space, overseeing that area, and I'm like, gosh, there's a whole lot of modernization that needs to happen. And frankly, the opportunities are overwhelming. So I'm figuring out how we prioritize and get things done, is where I'm at. And we're hearing feedback from this group, I think, about what matters most to you will help me to focus, because there's a lot. So, we can and we will do better together. I just worry a little that, the change is going to be hard. And some of the solutions that I've seen, the technology solutions, may feel like it's making things worse before it gets better. And the example I want to give on this is one of the solutions that integrates into the electronic medical record for ordering something that could potentially give you a real-time authorization is requiring the doctor to click on boxes that say, yes, I've met this, I've met that, I've met that. And I'm kind of like, oh, I can already hear death by 1,000 clicks. I already have carpal tunnel syndrome, but I'm Because right now, some of those things I understand go to like a whole different department that like takes care of it. So please bear with us as we try to find the system that will get us to this like, faster, better place. We're trying to find the best possible. But we are committed to modernizing this. Technology will help us. It won't be today. It won't be tomorrow. It's going to take a few years. You know, when I look at how long it takes to implement a program within my organization, I worry about the speed of our ability to move with these necessary changes and, you know, to get it right. You know, like if you implement it sloppily and it doesn't work well, gosh, that's probably even worse. And so I'm committed to improved communication and collaboration as we try to move forward. So thank you in advance for your partnership and for this conversation. You know, I think it's just
Thank you very much, Dr. Stefanie Park, for being with us this evening and for your wonderful presentation, being so transparent. It's been a pleasure to work with you in a number of meetings and listening to the work that you're doing. I think it gives us all a lot of joy to know that we have members that are doing many different things. So thank you so much. Want to really thank everyone who participated in this evening's conversation at HMA. We know you have your choice of evening activities, so we are grateful that you chose to spend some of that time with us. In the next week or so, we'll be making this recording available online and also the PowerPoint as well. So you can look for that via the HMA website. Until our next time, mahalo and have a great week as we continue our festivities here.